Hello, everyone. Thank you. Good evening, depending on where you are in the world. It could be good morning. And thank you for joining us. This is our first live interview for 2026. And it's no one better to get started than Dr. Shankara Chetty. And so I'll be talking about him in a minute and getting him to introduce himself. What I'll ask you all, if you haven't yet subscribed, please remember to subscribe. And if you want me to share your comments, what you must do is put up where you are from. So, say for instance, if I see someone do this, I almost always find time to share it. Just share where you're from. It's great for us to see that we've got quite an international audience and we look forward to being with you. Now, when it comes to 2026, as I said, my feeling is that I think this is going to be a tough year. And it's because that there just seem to be a number of signs that indicate that things are starting to heat up. But it's difficult to predict, as we can see. Well, what I've got with me is Dr. Shetty. Now, for those people who don't quite understand who Dr. Shetty is, he figured out how to treat severe COVID very early on using steroids and antihistamines, saved all the lives of all his patients on his own single handedly, almost over 14,000 people. And so when it comes to trying to predict and understand what is happening and where things are going next, there is nobody better. And so without further ado, I'll bring in Dr. Shankara Shetty so that he can share with us his views as to what's happening. So thank you, Dr. Shetty. Wonderful. Great to see you here.
Thank you, Philip. Thank you.
And so, just again, simple, quick introduction for those who don't know you. Who are you?
I'm Dr. Shankara Chetty. I'm a natural life science biologist, and a general medical practitioner in a little picturesque town of Port Edward, South Africa. I'm a family practitioner in this town, and I've used my scientific knowledge to formulate a hypothesis on what's happening with COVID and use that to treat all my patients. So, in a way, Philip, I've become a expert in COVID management. I was in, I was called by my institution of training to present as an expert COVID faculty. So I guess I'm considered an expert in COVID. I wouldn't like to call myself such. It's a learning curve.
Wonderful. So, listen, when we think about where we are now, one of the big challenges is that somebody had made the point that it's great to let's get everything aligned, talk about where we're going, nice and clean patterns. It seems as though we are in a moving target. Things haven't actually reverted back to normal. What would you say to that point that we are apparently not quite in a post pandemic stable period? What are your thoughts?
I think, Philip, there are too many variables that were pushed out of place during the pandemic for us to ever settle again. We're going to have to deal with this for a long time. If you look at what we're dealing with, we got a persistent viral infection, and the different variants influence different ethnicities in different ways. So you got that propensity. We're also sitting with a proportion of the global population that was vaccinated with variable vaccines, and different people might have taken different vaccines through their different injections. So there's all this variability that we're sitting with. And that makes the prediction of outcomes and affectations and the understanding of pathophysiology immensely difficult to predict and understand.
One of the things that I am realizing is that presentation of viral infection now seems to be different. The symptoms are so subtle. You know, in the good old days, if somebody had a flu, they knew they had a flu. You know, they coughing, sore throat, runny nose. Now all they seem to get is a little bit of a headache, some fatigue, and then apparently over until a few days or weeks down the line, everything kicks off again. Are you seeing a similar pattern?
Yeah, I think, Philip, what I put that down to, with the Omicron variants that are circulating, they are neurotropic. We haven't really been exposed to neurotropic viruses before in this highly contagious situation that we have. And of course, we don't develop immunity, so there's repeat infections. So you get a lot of patients presenting with a headache prior to developing any body aches and pains or the typical symptoms of a viral infection. So it starts unusually. You're seeing patients present with neuropathic symptoms before the viral infection actually shows up. I've had patients present with a fiery sore throat, but on examination, there's no redness or anything like that in the throat itself. So you'd expect that a patient with a severe sore throat that can't swallow will have severe inflammation in their throat, but there's nothing. So is that a neuralgic or neuropathic symptom? That you feel the soreness in your throat, but there isn't actually inflammation there. It's a nerve symptom rather than a pathophysiologic process in the throat. So there's this confusion. There's so many different things that we're seeing that are so unusual. But I think, Philip, if you're a good clinician and speak to your patients, they generally know what's wrong with them. And if you follow timelines, you can come to a reasonable understanding of what's triggered the process. And in most, it's either a viral infection or related to a dose of vaccine that triggered the process.
Yeah, I think that sometimes you have to go back to when people started to feel unwell and
Yeah,
the patterns of
always.
symptoms that they had. And you're right, sometimes it is 2 years ago or 3 years ago
Yeah.
that the symptoms started, and a lot of people are struggling like that. You'd mentioned to me a case that you were dealing with. What was that one like that you were handling in this gentleman? What did you see?
Philip, unusual. He presented to me 2 years after the onset of his initial symptoms. He was having constant tonic-clonic seizures. Uh, the seizures were limited to his head and face. So he had this, whenever he had a seizure, he would go into the state where there was a constant twitch of his head. Uh, he came and saw me. We had an hour's consult. In that hour, I had to speak to his wife. He was not conscious or were not in the room with me. In all that time, he just sat on the bed having these convulsions. His wife explained that this started 2 years ago with the second dose of a vaccine, the Pfizer vaccine. He had been for all the tests, MRIs, EEGs, the entire toot, and there was nothing that actually stopped the seizures, helped him improve. But just from understanding the timeline, from the vaccination to where he was, there's only two things that I actually deal with: the immune dysregulation and the clotting issues that come with it. So I put him on the modality of treatment I use to try and stop those cycles with antihistamines. And remember, Philip, it must be done concurrently. You can't break one end of the cycle and not the other, and then break the other. It keeps triggering itself. And within a week, we had him 95% back to himself. But in the second week, when I decreased medication, I always look for rebound. And in that second and third weeks, he started to rebound back to about 60% of where he was. And when speaking to his wife and understanding that there was rebound after the first week, I knew that the course of steroid that I put him on was too short a course. So those patients that have long-standing illness require a longer course of steroid to keep them in so-called remission from the immune dysregulation. But if you looked at a case like that, Philip, with seizures, gut upset, all these little bits and pieces that he was having, you'd never put it down to an immune dysregulation if you weren't clued up on that being the cause of this. The
Yeah,
diversity of systems affected, I don't think doctors are aware that this is the diversity of what an immune cell can do.
yeah. So over the years of talking to so many people, looking at the research, this is where this paper came from, the central roles of macrophages in long COVID. But based on what you're saying, I was just pulling it down here to this image here.
Yeah,
Based on that neurological presentation, I would say brainstem inflammation,
yeah,
secondary to choroiditis, secondary to activated macrophages, and this mast cell amplification, no wonder you get these responses. The problem is that these immune cells are not easy to get rid of. Are we just buying time if they have spike protein stuck in them?
Yeah, I think that's the big problem, Philip. When you have a viral infection, the exposure to spike protein is relatively transient. But if it triggers a process, like a bee sting, you just need one bee sting to trigger that process. But you're not constantly sitting with the bee in your bonnet. Uh, what happens is that if you manage to suppress the reaction, then the body resets itself relatively quickly and you're back to restored. When you have the vaccine, then there's a couple of things going to happen. You got a constant production of spike protein. So if you have an immune response to spike protein, you're in trouble because you're allergic to that bee sting and that bee ain't going to leave. Secondly, spike protein on its own is toxic when you're exposed to it. Now you've got a prolonged exposure to spike protein with the vaccine. So the length of exposure with the vaccine is far greater than with any viral, transient viral infection. And of course, that brings into play the long term problems with spike protein exposure. So
But
you're dealing with two subsets.
just to clarify, though, there are quite a number of people who haven't been vaccinated and still have long COVID like patterns. So it's
Yes.
not just the vaccine spike protein. What about the combination where they get vaccinated,
Yes.
infection, reinfection, vaccinated? This is now where we have a cumulative picture of spike protein immune responses and immune exposures. What does that look like?
And that's where I say, Philip, we've touched so many different, shifted so many different variables that with every patient, you're going to have to really sit and take the time to understand what's at play with that patient. Some will have overwhelming immune dysregulation. Some will have overwhelming microclotting symptomatology. Uh, yeah, each one you got to look at. And of course, there's the predispositions that were there before they ever were exposed to the virus or the vaccine. So if you have people that had pre-existing atopy, that will worsen with the exposures. So a lot of people, when you question them, will notice that their pre-existing conditions worsened from the time they took the vaccine or from the time they got COVID. They've not been the same. But on the hopeful side, Philip, I've had patients who presented with what they were told was chronic lung disease where doctors did MRIs and found there's extensive fibrosis and all that kind of thing. But with the appropriate treatment, their lung issues actually resolved, and 6 months down the line, there wasn't any sign of fibrosis. Now, fibrosis doesn't disappear. So, looking at that, was it misdiagnosed as fibrosis from an X ray, or are we seeing different X ray pictures from different lung pathologies that are being misdiagnosed? I had this issue with a radiologist that routinely does my radiological work. When I sent him patients during COVID, he'd write back to say viral pneumonia. So I had to write to him to say ground glass appearance is not viral pneumonia. It's a differential diagnosis between viral pneumonia and hypersensitivity pneumonitis. And by ignoring that, you're directing doctors to a viral pneumonia, and this isn't a viral pneumonia. And he eventually looked at it and actually then afterwards started training doctors on how to spot hypersensitivity pneumonitis because he realized it was a misdiagnosis. So even the tools we have for screening and diagnosis are going to become obsolete. We're not going to understand the picture because the pathophysiology has changed. And we've never seen this pathophysiology before to correlate it with anything that we have in experience.
I'm going to ask you an important question, Shankara. If there are clinicians watching this, they are already experiencing the awful feeling of having patient after patient come in front of them, normal tests, they are not feeling well, and they cannot find anything wrong. And effectively, they have to tell them that, you know what, this is probably in your head. But at the same time, they have this feeling in the inside of them that I don't know what's wrong with you. How does that feel day after day after day after day?
Philip, I guess you're going to have to ask yourself why you keep doing the same things. It can be very deflating if you're not assisting a patient. After all, that's what your job is, to heal people. And if you find that you can't do that, then it can be very disempowering as a doctor. But on the flip side of that, you don't tell a patient there's nothing wrong with them. The patient came to you because there's something wrong with them. You got to swallow your pride and say, I'm not sure what's wrong with you. I can't find what's wrong with you. And then find someone who can help you find what's wrong with that patient. That's why we have specialists and super specialists and to investigate and the rest. And as well, Philip, a lot of the medical fraternity push the vaccinations. And it's almost like you don't want to go there, and that's the biggest cause of all the problems. And if you refuse to go down that road, then you're going to disregard your patient, and you're never going to fix the problem. So I think there's many different things at play when it comes to clinicians not being able to solve this. I would have thought that clinicians, when they encountered a problem like this, would have taken the opportunity to go and study and look at what's new and figure out new ways. uh, I guess at the end of the day, it's the curiosity. And I guess being a doctor, Philip, when you see new things, it should spark that curiosity to go look and figure out what's going on.
But
Medicine
what
keeps evolving. You can't just rely on what you learned in medical school, and that's that.
so the problem is that medicine has become so dependent on protocols, guidelines from approved experts. But what happens when the approved experts don't understand and don't know where to go themselves? Suddenly, the whole system is lost. One of the things I find fascinating is that at the moment, if you ask, I think globally in medical schools, they are not teaching medical students about COVID.
Yeah,
Can you
and they
believe
should.
that?
And they
But
should,
but
Philip.
but they can't because they don't understand it. So can you
I
believe?
think more, Philip. Not that they don't understand it. It's an acceptance that what you did was incorrect. You know what I mean? You say don't. It's not that they don't know where to go. They don't want to go there. That's the bottom line. They know where to go. They know what the cause of the problem is. It's accepting blame. So I'd rather not accept that there's an issue there. Now, if you're starting with that premise that you don't want to go there, how do you expect to learn and fix the problem? So, like I said, those that refuse to learn are going to become obsolete. Patients are going to go back to them and find that they're not getting better. And there's a few that will stand out as doctors that are actually helping patients. And that's going to make a huge difference. So, yeah, we got a tough year ahead coming. But like you said, Philip, it's the education of doctors that will
Yeah,
help.
I think one of the challenges is that in medicine we don't have the luxury of narratives.
Yeah.
What that means is that if you are saying that you don't believe this is a problem, it's kind of like having somebody put arsenic in the water supply and everybody's getting sick. And you don't have the luxury as a clinician to say it's impossible for arsenic to be in the water supply if you are finding people are sick and you can't find the cause. You need to
Yeah.
figure it out. So you can't be political and say, I don't believe that. Everything is on the table until you can figure out what is causing the problem. And I think that this is part of the problem. Too many people are stuck in narratives where they believe this is what they've been told. And even when the evidence doesn't fit, they can't shift out of these narratives. And that is a great danger to patients.
Yeah, it is, Philip. And I think as well, ignoring what's transpired has put them in a difficult situation, that we have such a complex set of pathophysiologic processes that were disrupted, that it's going to take a lot for you to get up to speed now and understand what has happened with the patient itself. So yeah, it's going to be very confusing. I see it all the time, Philip. Patients coming to me with histories of 1 and 2 years, went through every medical test and found nothing wrong, but they're still unwell. We're also seeing, Philip, these sudden heart attacks, sudden strokes in a younger population. That is unusual, and that usually follows a COVID infection. I have a person that I am aware of, the local supermarket just down the road. There's a young lady that was working there, 26 years old. had a COVID infection, recovered from it, and I think about 12 days later had a sudden heart attack in the middle of the night and passed away. Now, for a 26-year-old to die of a sudden cardiac arrest is very unusual, especially for someone fit and healthy. But when people told me about that, they asked me, "Did you hear that this young lady just passed away in her sleep?" And my first concern was, did she develop microvascular clotting that was not diagnosed? And when I look at microvascular clotting, Philip, sometimes I see a raised D dimer, sometimes I don't. But when I examine patients, they will present with peripheral ischemic symptoms, those kind of things. And just from a clinical suspicion, I put them on anticoagulation, even with the normal D dimer, and they have improvement in their symptoms. So I think your clinical examination of the patient and your suspicions based on what we've been through have become more relevant than any testing would bring to an understanding of diagnosis.
This is going to be very difficult for Western medicine.
There's
You
where it's
know,
lost. Yeah.
it is completely outside of the standards of guidelines and protocols and this and that, because this is now reading what a patient's symptoms are, analyzing patterns. And as you said, very often, if this is a chronic pattern, the blood tests are normal. I mean, the amount of times these days I'm seeing patients who we know have COVID are sick with it and they barely have an inflammatory response, but they're sick. This is like a completely different kind of medicine presentation. It's very difficult if there is no framework.
And I think, Philip, as well, it's the education of patients as to the change in the presentation that helps us draw their attention to the severity of what they might dealing with, what they might be dealing with. There's an underlying thing festering, and they might not be aware. So with all my patients, I explain to them how COVID works, and I explain to them that look, you can have a sore throat for a couple of hours, and it disappeared, and a few days later you start feeling unwell, but you've forgotten about that sore throat that you had a few days back, and it was transient and really of no consequence, and that triggered an immune problem, and now so you're starting to feel the symptoms of it. So I think educating people as well, Philip, makes them recognize something's wrong. uh, I don't want patients coming to me 2 years after falling unwell and not recognizing that they're unwell. So I educate patients that a week after you get any flu, where be it mild, transient, whatever, you better be 100% back to yourself. If not, there's suspicion. Something's wrong.
I want to take you back to that young lady because I've also seen similar patterns where they have a very mild viral infection, sometimes just exposure, and then have a major event, sometimes 10 days, 2 weeks
Yeah.
after that exposure. The bit that I think is very difficult is the fact that sometimes their symptoms are so non-specific. How can you differentiate that from the patients who have a mild infection are actually okay?
That's going to be the very difficult thing, Philip. But I think repetition of infection and the patterns that it follows with each individual becomes important. Uh, to put it in a way, Philip, you tend to react in the same way with every exposure. But that reaction is dependent on your unique set of genetics and how you respond to this virus. So each patient has to be taught what an inappropriate response actually is for them. The neighbor might react differently. So, for those patients where when they've had COVID, they've had severe immune dysregulation, it might have presented with a specific kind of symptomatology. And I asked them to remember that. I had a gentleman that came in today. Uh, he had a viral infection for 2 days and it went away, and he's been fine. But he came in today to see me, a bit fatigued with a chronic cough. So I expected, okay, there's some upper respiratory dysfunction going on there. But he had, with no history of injury, a right knee inflammation, severe right knee inflammation. But he hadn't fallen, and yeah, the timeline was the same as his chest. So I treated him, but I explained to him that look, the next time his knee pains, It's a good indicator that he might have just had a COVID infection again. So some people have these unique symptoms. With myself, I have on my right side, my eighth dorsal root on my vertebra that starts to pain. And when I have that pain, I know it must have been a COVID infection. Now, in that paper you were talking about, they spoke about macrophage activation. And remember, these macrophages will migrate to any site of pre-existent inflammation. So if you've got slight inflammation somewhere in your body, besides the chest pathology and the gut pathology, you'll also get that pathology flaring up. And so that's a good indication because the ordinary flu doesn't do that to you. So it's these unusual things that occur post-viral, Philip, uniquely to specific people that we need to educate them about so that they can quickly realize that might have been COVID. I had a patient come in maybe 2, 3 weeks ago, and I discussed that this might be COVID because he had gut and respiratory symptoms. He didn't believe me. People want COVID to be behind them. But what he did was he went to the lab immediately and tested himself. It came out positive. I think he had 7 people in his home for the holidays. 4 of them were unwell. He tested all of them. 5 of them turned out to be positive for COVID. So it's just that we're not testing, it's circulating, we're not realizing the gravity of what this virus can actually do to our immunity. And so people think, if I didn't take the vaccine, I'm safe. But there are those of us, like myself, Philip, who react very disastrously to spike protein. So when you talk of a week later things starting, I'm all too well aware of that.
So a lot of people want COVID to be behind them. And when I look at the trajectory of comments, people are saying, this is over. Come on, get beyond it. Stop scaremongering people anymore. They just want this to be behind them. And what's interesting is that public health largely are following the line, meaning that they're not trying to say, actually, no, this is still pretty important. Everybody is incentivized at the moment to pretend COVID is behind us. How dangerous is that?
I think it's very dangerous, Philip. It's going to have population wide impact. And yeah, things might not be relevant to you until they affect you. Then it's relevant to you. At the end of the day, as much as everyone wants COVID to be over, it's still circulating. And we need to understand what's happened. Philip, this was a lab engineered virus. Uh, we can put it behind us. But do we put bioweapon research behind us? Do we put all the things that brought us here behind us and act like it didn't happen and let's move on? Move on to what? This problem is going to recur. So at the end of the day, yes, I'd like COVID to be over too. I'm tired of seeing COVID. I'd like to go back to practicing as a doctor should. But unfortunately, this is the population I'm faced with. These are the injuries that are prevalent in my population, and I'm gonna have to take the time to understand it and find a solution to it. And that's that. Whatever anyone else has to say is irrelevant simply because it's not impacting positively on the health of my patient. All the data we collect, all the talk we have, all the narratives, all the dismissive comments, all mean absolutely nothing if it's not impacting on what's happened and on the lives of my patients. People can't tell me that they're unaware of these unexplained deaths that are occurring around us. Uh, yeah, we can turn the other cheek, but we're seeing loved ones, young, passing away. When is it going to hit home that this is what we're dealing with? Or are we going to be a society that is complacent enough to let the people that have done this do it again?
Yeah, this is a serious question because as we look forward, one of the thoughts that I am trying to work out is how much longer can population immunity hold up under the ongoing, I mean, this persistent impact of infection after infection? Now, I'm going to show you a chart that I developed when I was talking about Gert's prediction with regards to Hivicron. And what I had said then, and I still kind of hold it now, is that I actually think that this kind of virus is already circulating. But I think Gert expects it to be more like severe COVID in the early part of the pandemic, that kind of presentation. I suspect it's not going to be. What I think is happening is this kind of step where persistent infection goes to immune dysregulation, smoldering inflammation, metabolic collapse, and the end stage sepsis, where they just die. Where I think that Garrett is expecting is that this is going to predominate. But based on what I'm observing with the population, is it's a stepwise move where more and more people shift into these phases. So you may only see this really severe thing maybe a year or two, 3 years, I don't know, down the line.
Yeah.
When you look at this, what are your thoughts about that kind of?
Yeah, Philip, I think the progression through that, from getting infections to having the persistent immune dysregulation, uh, to going in from the persistent immune dysregulation to chronic inflammation, to that chronic inflammation causing other sequelae, metabolic problems. Each person will progress through those phases at a different rate, depending on one, their predispositions or their pre-existent conditions before they came into this, the way they respond to the virus, whether they've been vaccinated. Their health status plays a huge part in it. Those that live unhealthy lifestyles will progress through it faster. Those that live healthier lifestyles won't. Those that are able to isolate from big populations won't get so much of infections. That will slow the process. But everyone is on this trajectory to that end stage of metabolic dysregulation and then chronic illness leading to the sequelae that we see. So each one will progress at different rates. So, yes, we might be seeing the early stages where we've got a lot of people with immune dysregulation, a lot of people with repeat infections, a lot with these underlying chronic inflammatory process. But we're also seeing a large proportion of people progressing to the metabolic side of things, the rise in diabetes, all the different metabolic issues that we are now seeing, thyroid issues, and of course the long-term immune problems that go with that. And then from there, it becomes persistent viral infection, or it becomes end-stage viral infection. So how you progress through that, I think, is dependent on your propensities, family history, what you've been exposed to. So it's quite complicated. Again, a lot of variables to dictate the progression. And each person's good, they're going to find it very difficult to stem that process if they are unaware of where they are in that mix.
Do we need a revolution in medicine where medicine needs to break free of the shackles that are around it? Because otherwise, we have a situation, and this is something, again, I've said on a few occasions, but people don't quite understand it, which is that when you have systems that are largely protocol driven, there are times when it is safer, more defensible to just let people die. Even if it bugs you personally, you are safer to not do anything. We saw that in COVID, where early treatment was just completely ignored and people just waited for people to die. Can medicine go through that kind of ethical dilemma again?
I think, Philip, medicine should have been restructured more than 20 years ago. We allowed this capture to come into it. 25, 20, yeah, about 25 years ago, Philip, is when medicine stopped to be a clinical practice and it became more a pharmaceutical endeavor. When you look at doctors that were trained before, well, in the 80s and 90s, they were trained more as clinicians. Symptomatology, all that was vitally important. Then from the 2000s onward, it became more about protocol driven. Pharmaceutical industry got involved. You weren't allowed to think outside the box. You had to toe the line. So all these things shackle doctors. And because of that, Philip, doctors just do what's in front of them, follow the protocols. Remember, we're dealing with life and death situations, and the last thing you want to be accused of is challenging someone's life unnecessarily. But then these are That's what you're trained to do. That's what you're trained to do. So why go through 6 years of training and they come out at the other end and they say, "Look, follow the protocol"? Why didn't they just give it to me at the start? I didn't have to have all that knowledge to do that. So I guess, yeah, medicine needs to be completely fractured and redone, completely redone. Philip, when I compare medical training, I was fortunate enough to be trained in the East, and there's a very different way of medical training in the East compared to what Western medicine teaches. And I think we need to come together as a global society and put together what's the best way, not medicine, but healing. How do we heal people? How do we as doctors convert into being healers, not just doctors? And of course, the ancient traditional systems of medicine need to come back into relevance. Maybe then we'll fix the problem, Philip, because right now our toolbox doesn't have enough tools for what's transpired. And so we got to look at it in a more holistic, broad-based way. We don't take into consideration simple things like the water that we drink. We're 70% water. We don't take into consideration frequency. We don't take into consideration electricity and charge. Medicine is devoid of all those fields, and that's going to make us ineffective in healing patients. I mean, Philip, a simple thing, and I've been looking into this for a while. We treat blood pressure. We monitor everyone that walks into my consulting room wants to know what their blood pressure is. And there's this preoccupation with blood pressure. But all the old medical systems use perfusion, not pressure. Now, as you grow older, perfusion decreases, pressure naturally has to increase so that you get blood supply to those distal places that are struggling to get blood supply. Now, in those kind of patients, that's a physiologic change, an increase in your blood pressure to improve perfusion to distal areas of your body. Now, if I look at that and I just on a value say your pressure is too high, not looking at perfusion, by putting you on a blood pressure medication and lowering your blood pressure, I will compromise perfusion to those areas. Is that the reason we're seeing Alzheimer's and dementia and all these different illnesses of age simply because we're over treating things based on values? Remember that blood pressure, Philip, the high blood pressure will cause a burst vessel, and that takes a very high pressure to do that. We still haven't proven that elevated pressures around 160 are actually damaging to the human body in any way. So why do we keep looking at normal? I think the medical fraternity's preoccupation with defining normal is a problem. I haven't met two people the same, and normal doesn't exist. I think the word average exists, and all the parameters we use are average. And the beauty, Philip, is if we stop trying to define normal, abnormal ceases to exist. We're all trying to be normal, but there's no such thing. So medical science needs to change. It needs to change
I,
completely.
I'd recently seen a post on LinkedIn. I couldn't find it where oh gosh, he's an oncologist. Doctor, he got into a lot of trouble in terms of COVID, and he is using specific drugs that rhyme with pectin and so on
Dr.
to
Marcus.
ah
Was it Dr. Marcus?
yes. I think so. And I was reflecting on a case that he had shared where he used some of these antiparasitics combined with CHOP therapy with some of the older prednisolone and some of the other chemotherapy agents, so an older system with antiparasitic agents, and had a significant remission of symptoms in a stage 4 patient. And I was reflecting on the fact that one of the biggest earners in terms of medicine research and development is cancer in terms of cost to treat. How is it that even in that we are satisfied with people getting cancer and trying to treat it and not really digging into the heart of what is going on in terms of health? Where did medicine become this kind of flaccid profession where we are satisfied
Yeah,
with
yeah, yeah.
not understanding stuff? What happened?
Yeah, it's crazy, Philip. Where medicine was always a science filled with curiosity. Uh, to examine it, I was taught, Philip, that you don't only use your hands, you use your eyes, you use your smell. I mean, a patient walks into my consulting, into my practice. I can tell you if they have a staph infection or a foot that's rotten, I can tell you exactly what the bacteria is just from the smell of that patient. Now, these are the passions you should have if you want to become a doctor, to constantly learn, to constantly grow, to constantly understand the processes that underlie these diseases so you can manipulate them. You can play with them. You can get your patient to feel a lot better. Medicine has moved away from that. I think because of the complexity of medicine, in trying to rationalize it, we brought in protocols and we brought in super specialists to do all those difficult things. And so I think, yeah, at some point, medicine completely lost its direction. Uh, we as doctors today are just meant to toe the line. Where's the point of doing that? Where's the curiosity in that? Where's the science in that? Where's the understanding? As well, Philip, doctors always were a community that shared expertise, shared experience. When someone discovered something, they wanted to tell everyone about it. Today, it's about patents and making money out of what you have, and you work very confined and secluded. You don't want anyone else to see what you're doing. I don't know how come medicine got that way. The ego got involved, and people want ownership of what they found. It's no more about sharing. It's no more about collaboration. I think I mentioned in many of the interviews, Philip, we lost the doctor's lounge. And that was the one place where all the development happened, with doctors sitting around a table, just chatting over all the problems they have with patients and getting the input of other professionals who have different expertise and different experiences. And that's all those. Medicine is about, Philip, having those light bulb moments. It's very complex. And suddenly you'll have a light bulb moment and I couldn't go and try that. But if you stuck within this framework of constantly following protocol, you're not even thinking outside the box. You don't even care to think outside the box because it's of no consequence to you. And that's where I think doctors have become complacent and just follow the rules. Don't get into trouble. I spent a lot of money and a lot of time becoming a doctor, and it's a very regulated field. And the last thing I want is for them to take away my license. So let me just stay within the lines. And that needs to get broken.
Yeah, so when we now look at where things are, Shankara, because at the moment, what has happened is that there is now a COVID inertia that affects medicine. So, in reality, even though research is happening, there are no clear innovative protocols, even for long COVID or anything. And so, there is now this period of time where nothing is happening. What does this mean going forward when we look at patterns of disease? Because as I see it now, the immune systems are no longer responding. And I'm trying to make sense of it. But if the immune systems are no longer responding as well, you would therefore expect more infections, later presentation, and critically more cancer. These are the three big ones that I expect. Any thoughts about what this means in 2026?
Well, Philip, we're already seeing more of those things. Increase in cancers, increase in opportunistic infections. I'm already starting to see the autoimmune issues starting to show up, the rheumatoid arthritis, and those kind of things. So yeah, it's everyone in their own rates are progressing to the same endpoint, illness, in via different means. And yeah, I think 2026 we're just going to see more of the same, but a lot more of the same, because we're getting to that point where if you look at last year, there were a lot of viral infections, a lot of long COVID. The world has awoken to accepting it. This year, because of the being accepting of what's transpired, Philip, we'll see a lot more of these cases being acknowledged. And I hope that we eventually see the true extent of what's happened. There was a post, Philip, someone posted that uh, patients that took the vaccine seem to fare better when they have a viral infection. But of course, with the viral infection of COVID, it's treatable. So they felt that the vaccine did well. It saved so many lives. But of course, you're not taking into consideration the excess mortality. and the other effects that the vaccine has caused. And so it's a horrendous price to pay for a slight improvement in immunity to a virus that's reasonably treatable. So I think at the end of the day, uh, when there's this awakening, we will then realize the true extent of what's happened to humanity. And we need that shock for people to stand up and realize that this has been a global event that's going to have affectation way into the future. We may never get back to normal.
Yeah, this is pretty serious. And I think that one of the things that I have been concerned about, I remember in 2022 when I spoke with Dr. Roz Jones, retired pediatrician. She was at her wits' end at the time when they were going to use COVID vaccines in children in first world countries. And when you reflect now on the potential implications as well, actually, I remember Gert was absolutely beside himself thinking that they were going to vaccinate children, because it is bad enough that you do it across the population, but going into the cohort, that low risk cohort, would bring unknown unknowns. I am now wondering, it's one thing when your parents get sick or your friends or family. But I tell you, if parents find that their children are sick because of stuff that happened around the pandemic, it's not so easy to just pass off. Any thoughts?
I think that parents should stand up, Philip. The bottom line, we're seeing what's going on globally, and the only way that these systems are going to break and be remade into what we want them to be is if population rises. We can't just be complacent and let bygones be bygones. We then live in the same problem, live with the same problems. So I've said this before, Philip. The systems that were designed were never meant to serve humanity the way they were. Be it a medical system, be it your financial system, be it your social systems. And for us to restart in a proper direction that actually benefits our planet and humanity at large, we need to break these systems and restructure them according to what the outcomes are that we desire. And so when you talk about, uh, let's call it civil unrest or parental unrest, it's something that's absolutely necessary. If someone did something to my child, I'll stand, and I'll never let never let it go by. And I think, unfortunately, the pain will dictate how we rise. I was asked this question with an interview in Sweden. How come South Africa is so clued up on what's going on with the virus and the vaccine, and Sweden is still so quiet about it? And I mentioned, I said, look, we went through a lot of pain fighting for our freedom, and a lot of countries have become complacent with their democracies. So it's going to take far more pain in those countries for them to actually rise and stand up against their governments. But this is what's required, Philip. If someone does you harm, you have to rise. We can't be complacent and sit down. And remember, we're not talking about everyone rising. We need a critical mass. We're talking about 15% of enlightened people standing up against what's happened, and we'll change the future.
Do you think we still need a reckoning? Because this is what is scaring a lot of the people who were in leadership. And if they're in leadership, it's therefore blocking their interest in doing the research that needs to be done to understand what has happened. But if they are doing this and they are at risk personally, will that discourage them from doing what should be done? Because this is where I suspect that we are. It almost needs a moratorium.
Yes, Philip, nobody likes to convict themselves. So they know that they will stifle this kind of research, but it's for people, Philip, to realize what's happened and stand up against it. But we can't expect the politicians and the researchers that were involved in this to fix the problem. They're not going to fix the problem. They'd rather sidestep it. And when you talk about reflecting on it and whether people will do want to, it's one of two things. We either reflect on this problem appropriately or repeat it. You choose. Do you want that we talk about this and actually figure it out and make sure we understand it? Or do we put it aside and say, well, COVID's passed with the with the full knowledge that there's a risk it's going to repeat itself. Do we want to go through that again under a different name?
And so, therefore, in 2026, what is more important? Is it doing the research or addressing the fact that leadership failed the public in this time? This is where it's a strange thing is that in order to just do the research first, you need the moratorium to just move forward. But if you do that, you then have a situation where people, if they got away with it before, would do it again.
Yeah.
So, can we get around? I mean, different countries have tried to do inquiries, but they all seem to come up with nothing, even though it's clear that there were so many things that were wrong. How do we get past that?
I think the simple realization, Philip, is that the will of government is not reflecting the will of the people. We're sitting with a broke system in all countries. It's the will of the people to have this looked into. They've had loved ones that died. They want to know what happened. But there's no will in their governments to actually do it. So, yeah, I'm not a conspiracy theorist, Philip, but I don't believe democracy is what it's made out to be. I think that a lot of the leaders that we have are chosen. They sell you stuff and on their campaign trail, but come into government and do exactly what was expected of them. We have in most countries a left and a right, both doing the same thing. It's like two hands clapping to the same tune. So whether it's your right hand or your left hand that you voted for, the sound that comes out at the end of the day is just the same. So yeah, I think we need a complete change in the way we elect our politicians, in the way we protect our cultures and communities.
And so, how much time do we have? Because my concern now is that as I was looking at some data from the UK in terms of this winter period in the UK. They had this flu virus that's circulating all through the world. In the UK, it showed it was circulating a lot in children, so in educational facilities. And so when I combine that with Christmas and the New Year, I expect this to be a massive super spreader event because the children then come, parents, grandparents, cousins, everybody coming together. You then have this massive spread of viral infection hitting everything. So I'm expecting this to be a very tough early part of the year. What will it take to get people to pay attention, though?
The pain, Philip, that's the only thing people pay attention to. When there's too many people getting sick, then suddenly it's strange, Philip. It seems population works on fear. The more fearful they get, then they stand up and listen. If they're not fearful, then they're complacent. Like you mentioned, cancer is the biggest money spinner because it's the biggest fear driver in medical science. So it seems like people respond to fear. And it's only when they realize the gravity of what's going on around them will they suddenly wake up to what's going on. Unfortunately, that's the way population is. Complacent, get on with your daily life, don't look left or right. Uh, that's where we're at. At the end of the day, we're not going to be able to change that. It's when people individually get very sick and suddenly realize I've never been that sick in my life. That's when the awakening happens that they realize something's wrong. Before that, it's the neighbor's problem.
Yeah, so then that may be the push because, as I said, when I think of 2026, what I see is that because so many people are getting infections, COVID is still circulating, it means that all conditions are going to increase
Yeah.
across the population. It don't know, makes the question though, what is the threshold? That it seems as though you're right. Maybe people have to be afraid. What is the threshold that will make people go, oh my goodness, we have really got a problem?
You see, where I see the issue with the fear, Philip, we're seeing this diversity of pathologies, right? So you hear of this youngster that passed away that had this flu a week ago. Then you hear of someone else that had a stroke in their sleep. Then you hear of someone else that developed Alzheimer's, uh, all related to the same pathophysiology. And because you're seeing this diversity, people are not putting two and two together. They know that there are more people dying, but it's easy to say, but they're not dying of the same thing. But it is the same thing. If you understood the underlying pathophysiology, it is the same thing. It's just affecting them in different ways. So if you had to get all these excess mortality that we see, if every one of those patients that contributed to that excess mortality died in exactly the same way, we'd all be up in arms, because then you'd see the extent of what has happened. But because you're getting all these different pictures, it's broad, it's diverse, it's diffuse, and you're not putting two and two together. It's easy. It's easy to to dismiss that narrative, to say no, there's different things happening. And of course, as well, we got to realize as well, Philip, a lot of people took the vaccine and would not want to admit that it's dangerous. You'd rather find every other explanation for what's going on around you than admit that it's killing people. Because then you're at risk. You're going to have to accept that you did something that's going to be challenging your life for the rest of your life. And you'd rather live blissfully ignorant rather than that with that monkey on your back.
That one is a biggie. And this one, I think, is part of the problem where we have converging issues where politically it's expedient to let things happen. From a population point of view, it's expedient to be ignorant of what can happen. And so you have the two things coming together, and we are sitting therefore on what I would call, even if you mentioned hypertension, suddenly leaving the whole world with no medication, not measuring blood pressures, not worrying about anything, just letting it run for 5 to 10 years. And then you see the heart disease, stroke, kidney disease, eye disease. And the worst part is, even if you try to intervene later on, the damage has already been done.
Yeah.
This this is where I think we are now. I suspect that the damage has already been done. If I use the hypertension analogy, the kidney disease is already there, the heart disease is already there, the brain disease is already there. All we can do now is mitigate the damage, which we're not even trying to do.
Yeah. It's a strange war, Philip. The shots were fired. We're waiting for the victims to fall. And I don't mean shots with any pun intended.
Oh my goodness. So listen, as we wrap up now, Shankara, I think that the main takeaway that I can see happening this year is more of the same. It's just the numbers are going to be increasing. It's going to be harder and harder to say that everything is okay. So the narrative is going to continue to buckle under the strain, but it seems as though the population will be happy to just continue hoping for the best. So we will see more deaths, more illness, but no clear change in trajectory or research. What is your prediction into 2026?
I think the same, Philip. I think 2026 brings a realignment, an awakening. We've seen that start last year with people awakening to what's happened, being more aware of what's going on around the globe. So, yeah, this year is a different frequency alignment almost for humanity. I think as well, we'll have more purpose and direction. So, we won't tolerate those things we've been tolerating in the past. We'll become more defined in the way we look at the world around us. With that awakening, I think there will be more people that will rise and protest what's happened. I think we need the population to stand up and rise and protest against the regulations that have brought us to this point. But it might not be COVID or COVID illness or the COVID pandemic that might be the main catalyst. But the way I see it, Philip, there's a whole lot of other socioeconomic issues that are coming into play, and that might be the catalyst for change. We're seeing financial issues, we're seeing social issues, we've got the immigration issues that we're seeing around the world. So we're seeing fragmentation and fracture of all cultures and communities around the globe. And I think it's that complete fracture of those communities that will bring the protests and bring the change, bring the uprisings that we need.
One thing is for certain, though, is that people can complain about various things. You can have no money, you can struggle with your housing, you can have problems with the family. But when you are sick, that's the only thing that matters.
Yeah,
Nothing else matters. And I think you may be right. Sadly, when enough people are sick, they will start to realize, oh my gosh, we need answers urgently. That's how a lot of people who have long COVID feel. And they have experienced this for 5 years now. And it hasn't yet hit a critical mass where enough people are sick. And so, therefore, there is still an inertia in the population that this is behind us.
yeah.
There is still a lot.
Just to
Mhm.
put context to that, I haven't seen a single vaccine injured patient who didn't know he was vaccine injured. The doctor might not want to believe it, though.
On that note, Shankara, so thank you again. I'll ask you to wait for me while we have the outro. Thank you, everyone, for joining us. As usual, stimulating, interesting, insightful from Dr. Chetty. We will certainly be talking to him again this year. Have a great evening.